check, like you can take a picture and your check gets deposited. That's
Hereby, I open this academic ceremony in which Jeffrey Chan will defend the academic thesis, The Impact of Neighborhood Environments on Lifestyle, Socioeconomic Health Disparities, and Cardiovascular Disease. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Pro-Rector, dear members of the Corona, dear family, friends, and audience members, in the next 10 to 15 minutes, I will give you a brief summary of the research entitled The Impact of Neighborhood Environments on Lifestyle, Socioeconomic Health Disparities, and Cardiovascular Disease. First, a brief background on the issue here. So cardiovascular disease is one of the leading causes of death in Europe and worldwide, particularly in the Netherlands. There's 1.5 million people with CVD, and about a quarter of all Dutch deaths in the Netherlands are attributed to cardiovascular disease. And just like many other conditions, preventable conditions out there, those with lower socioeconomic position are more susceptible to CVD, or also known as heart disease. Heart disease includes stroke, myocardial infarction, peripheral vascular disease, so it's all encompassing of all those conditions there. So we know that there's common lifestyle factors and contributors and environmental exposures that contribute to cardiovascular disease. You can see here pollutants in the air, so toxins, air exposure can contribute to heart disease. Alcohol and smoking, of course, can constrict the blood vessels and can contribute to hypertension and other intermediate conditions progressing to cardiovascular disease as well. Depression, anxiety, mental health conditions too, those can add stress to our heart and arteries, and as well as the most common is poor diet and lack of physical activity, as well as long periods of sedentary activity as well. Particularly with diet and physical activity, diet is rated poor in about a third of Dutch citizens, and half of those living in the Netherlands don't have enough exercise as well. So despite public health messaging and communication and recommendation from GPs and just common sense, this is still lacking. We're still lacking in terms of exercise and just achieving quality nutrition as well. So this brings up a question, what can we do upstream and proactively to make it easier for us to not go out of our way and to make having an easier diet, having a high quality diet easier, and to make it so that we can be more physically active without having to intentionally make an effort to. So how can we have that built into our lives and have it naturally just steered to where it's not too large of a task? So proactively, we have to start looking, okay, what upstream determinants, what other factors can we affect, can we change, what can we address to make that easier? One solution that has been looked at in the past several years is looking where we live. So neighborhood environments, so conditions that have been looked at in the last several decades that have contributed to cardiovascular disease, like we saw, air and noise pollution, so just living near freeways, motorways, and the toxins that get secreted from those vehicles. Areas that are known as poorly walkable, so lack of green space, lack of walkable areas, A lack of places just to generally engage in physical activity. Unhealthy food sources, also known as the food environment. So the shops, the restaurants, how healthy are those places? And it's been shown that roughly that areas where the quality of the shops and foods, the healthier they are, they've been linked to actually healthier diets. Like we said, stress, depending on the neighborhood that they live in, and lack of safety and social connectedness too, also known as social cohesion of the neighborhood. How well do the residents connect to each other, how much do they support each other, and how often they interact with each other too. And lastly, inadequate resources like hospitals and community centers as well. A lack of those and preliminary findings have led to the contribution of cardiovascular disease. Given those findings within the literature in the last couple decades, there's been inconsistent and incomplete data driving to those conclusions. So for instance, food environments, most studies have just looked at just a few types of food establishments like fast food restaurants or markets. In terms of data collection too, the questions have been involved just fruit and vegetable consumption or fast food consumption, but not the entirety of the diet. So we're not too sure based on those past studies. Lack of longitudinal data, so most of the studies are cross-sectional, so observational at one period of time. So it's hard to make a causal inference based on those studies as well. There's been few outcome studies, so in terms of the food environment and walkability, most revolve around behaviors, but not as much around cardiovascular disease or diabetes and so forth. And finally, when evaluating the neighborhood, there have been issues with spatial misclassification too. So that's a fancy term for how do we define the neighborhood and our environments? Is it within a few blocks? Is it an administrative tract? Is it a postal code? So there's been a little bit of disparity and confusion around that as well in those studies. So that leads us to the aims of my thesis and dissertation. So trying to add to the quality of the data collection here. How are environmental factors related to modifiable lifestyle factors such as diet and physical activity? So we're focusing on those two exclusive lifestyle factors. Do built-in social environments have an association with incident CVD? So adding to the depth of the literature that's lacking outcomes. And finally, to what extent do environmental factors contribute to socioeconomic inequalities in CVD as well? So how did we do this? So we used the Maastricht study, so it's a population cohort study right here in the Maastricht area, in the greater Maastricht area. Involved nearly 10,000 participants, middle to older age. And to gather physical activity and sedentary behavior, we used an accelerometer as opposed to self-report. So that was adhered to their thigh for about an 8-day period. So it collected movement and walking and other types of activity. Participants completed a vast amount of questionnaires, and in particular, we used a food frequency questionnaire, questions on alcohol use, smoking, and cardiovascular disease status. So the three, again, that we were focusing on, food environment, walkability, and social cohesion, with the help from our colleagues in Amsterdam, the GECKO Consortium, we were able to obtain an objective measure of walkability as well as social cohesion, in addition to our perceived measures of the walkability and the social cohesion of the neighborhood as well. Methods, we measured socioeconomic position primarily through education, and as we had more data later on, we used income as well as occupational status as well. CVD reporting, so every year there's a follow-up questionnaire with our participants where they were asked if they were diagnosed with certain conditions under the umbrella of cardiovascular disease. So we were informed of new diagnoses of cardiovascular disease. And unfortunately, those with myocardial infarction or heart attacks resulting in death, we checked those through our Statistics Netherlands database to confirm those for those unable to report. So what did we find in terms of the food environment? We actually found that the food environment, so the quality of shops and stores around one's neighborhood, did not relate to diet quality. And you can see from the heat map there, We used a 1,000 meter radius from each individual address. You could see the red, there's pockets of unhealthy food shops in those areas, followed by green where they were a little bit healthier, slightly healthier. Overall, that we did find that the food environment is generally slightly unhealthy, but otherwise neutral for the participants in our study. In terms of walkability, we found a discordance here. So in terms of perceived walkability, we found that those who perceive their neighborhood as walkable were actually more physically active, but using the objective scale of street networks and destinations and pathways and green space, we actually found that they were less active and more sedentary as well. And you could see here on the heat map some areas where it was more walkable, and the red denotes less walkable. You could see just for the intention of this map, the postal codes don't correspond to areas. So you could live, one can live on the edge, and they could be misclassified using previous studies that used administrative codes as well. So what was unique about our study is we used individualized environments within 1,000 meters. In terms of social cohesion, using the perceived and objective scales, we found that those who perceive their neighborhood as very cohesive were more active, they ate healthier, they sat less, and their body mass index was actually lower as well. And this was consistent across both measures. In terms of CVD, heart disease, similar as our finding in terms of the food environment. So the food environment didn't relate to diet quality, neither did it relate to cardiovascular disease as well, so that was a null finding. In terms of walkability, again, just using the perceived scale, there was a relationship between higher walkability and lower cardiovascular disease. We did not find that with the objective walkability scale of street networks and such. And in terms of social cohesion, using both scales, perceived and objective, there was a lower incidence of cardiovascular disease. Combining all the environments together, so taking into account those with lower socioeconomic status, so if we combine the food environment and just perceived walkability and social cohesion, so if they lived in neighborhoods that had a lower, less desirable trait of those, we found that the environment directly in itself contributed to 12% of the explanation of CVD, and then lifestyle factors still prevailed and explained 62% of the rates of cardiovascular disease. And by a small amount, the neighborhood actually preceded lifestyle factors, so the environment had an effect on the behavior before cardiovascular disease. So that was a small percentage, much smaller than we hypothesized, but on a population level, that is actually still a pretty large effect size there. General findings. We found throughout all our studies, no matter what type of measures, food, environment, social cohesion, or walkability, those with lower socioeconomic status tended to live in the least desirable of those neighborhoods as well. And so that brought to our attention that socioeconomic inequality exists within neighborhoods too, and it's quite prevalent within our participants. So to wrap up, the food environment, again, had no relation in the form that we used and the way that we measured, had no relation with diet quality. In terms of neighborhood walkability, just the perceived questionnaire was related to higher amounts of physical activity. And in terms of social cohesion, using both scales, diet quality was better, was higher, they were more physically active, and they were less sedentary. Taking into account CVD as our outcome measure, again, no relationship with CVD with the food environment. Perceived walkability, there were lower rates of cardiovascular disease. And in terms of social cohesion, lower body mass index, so lower weights, lower rates of obesity as well that we found, and lower cardiovascular disease. So taking into account the findings that we had, this tells us from a practical and policy standpoint that, okay, there's neighborhoods that lack these qualities, and they could possibly make it difficult for those living in those neighborhoods to achieve active positive behaviors like being more physically active and higher nutrition or better quality nutrition. In comparison of lifestyle factors and the environment, lifestyle factors prevailed more than the environment in itself. And we hypothesized that the environment would contribute a little bit more, but by far lifestyle factors independently contributed, especially poor lifestyle factors contributed to higher rates of CVD. Lastly, also from a policy standpoint, so careful neighborhood planning, methodical design, we believe that can reduce inequities and make it more attainable for residents to achieve healthy behaviors. That there shouldn't be neighborhoods that are less desirable. So by looking at that map that we saw earlier, that tells us there needs to be some work in terms of city planning, both at the municipal and provincial and the national level as well. And when planning these neighborhoods too, a lot of these governments should include more residential feedback involvement, whether it's a focus group or a listening session. That way it'll accommodate the variations of interests and lifestyle factors of the specific populations that live there too. It shouldn't be a top-down approach. And overall, municipalities and governments, that when they're responsible for permits for food establishments, and so they have a role in dictating what type of the healthiness of the food shops that will open up or stay active within a certain area. So they have control over that, and we saw in one of the previous slides that there are areas where there's plenty of unhealthy foods, and governments know about this, and we should act on that. And finally, residents who perceive their environment as physically active, as cohesive, that tells us that we should take action on satisfying this, and also identifying what makes those areas cohesive and tailored to making them more active as well. And then, thank you for your attention. I'll give the word back to the pro-rector.
Thank you very much for your presentation. We will now start with the opposition, and the opposition will be opened by Professor Krohne, who was also the chair of the assessment committee of your thesis. She's Professor of Health Promotion at the Department of Health Promotion from Maastricht University. Professor Krohne.
Thank you. Dear candidates, first of all, I really enjoyed reading your thesis. Congratulations to you, your supervisors, and it's a very interesting and a well-written piece of work. And I would like to start with an easy question, maybe. I want to start with the cover. And I would like to ask you, why did you choose for this cover and this environment? What makes it that you like this?
Mm-hmm. One highly esteemed opponent, thank you for your comments.
Yeah.
One of the main findings that stood out that I was not familiar with at the beginning of the dissertation was social cohesion, and as you saw in the findings, overwhelmingly it was related to positive lifestyle factors, yeah. Both the objective and perceived, and a town square in terms of addressing that and trying to facilitate a cohesive environment. A town square gives the residents and the locals the opportunity to interact with each other, and even though they might not know each other, it gives them that space to see each other, and that's, yeah.
That's the reason for this thing.
Yeah.
Yeah, they don't actually really interact, but there was one thing that I missed, mm-hmm. That is green. There's no green in it.
Yeah, unfortunately. Yeah. Everyone has their preferences.
Yeah.
Yeah.
Yeah, so that's the next version then.
Mm-hmm.
But to continue, when I read your thesis, I was really intrigued by the somewhat conflicting findings that, for example, this objective neighborhood walkability wasn't related or even negatively associated with physical activity, while perceived walkability was. As cohesion was actually both perceived and observed were important, significantly associated. And then I was wondering, because I'm also writing a paper using also this social cohesion data, and I went back to these papers, and I actually refer to you in these papers. I'm still in the writing phase, but then when I looked at our paper, then I saw that the neighborhood social cohesion, based on this livability index, we used 5 aspects of social cohesion. So I don't mean the whole livability index, but only the social cohesion.
Mm-hmm.
It was the diversity by life stage, population density, and mutation bias, that was in it. But we also had perceived social cohesion in it. And that seems to be a questionnaire that is filled out regularly by a random sample of inhabitants. And based on that, they also have a perceived social cohesion in this index. But you didn't use that one in your objective neighborhood environment. Could you explain why?
Yes. So there's a in-depth technical document that they used when developing the social cohesion subcomponent of that, and they actually found with the Dutch population the social cohesion questionnaire derived from the Sampson version had low correlation actually.
Low correlation with the other factors, or?
Yeah, in the Netherlands in particular. It was interesting. And so what they found was, based on municipal data, administrative data, they narrowed it down to those 3, 3 measures of the mutation rate, the density, and then life stage diversity. So it was quite interesting that they found that it was low. Yeah, there's a low correlation using that question.
So the social cohesion, so as measured with the questions that they had, it's not related to the other diversity by life stage and population density and mutation rates.
Yeah, one of the theories was, if I can remember correctly, the translation.
Yeah.
And then the application of the Sampson, and I think there's another one used too, possibly. It did not correlate to. Yeah, there was a poor. The questionnaire performed poorly, so that's one of the possible reasons why they omitted that.
Okay.
Yeah.
Yeah. So if you would advise me, because I'm now with this data.
Yeah.
Should I use this perceived social cohesion, or should I leave it out, or should I treat it separately as a separate aspect of neighborhood social cohesion? So what would you advise me?
Mm-hmm. Yeah, in terms of spatial epidemiology, we see that over the past several decades that no one measure stands out, and so in terms of practicing triangulation, the more measures you have, that especially in one project, that will kind of give you more robust findings. And I think including both would be actually helpful to see if there's some type of disparity between the two.
Yes. So then both in one index or in separate index?
Separate index, I think.
So yeah. But then I will put it on a neighborhood level then, and not on individual level, because the population that I have didn't because it's the statistics Netherlands data, so we don't have data from all individuals, only from at least for the social cohesion, perceived social cohesion questions. We only have that for a random sample every year, so we can only use it at neighborhood level. So that was a reason, and that was also the reason why I'm thinking, should I then use it at a neighborhood level as a separate one? And say, okay, you have the neighborhood objective social cohesion and the neighborhood perceived social cohesion.
I would do both, just to confirm the findings, similar to how we used the perceived and the livability meter.
But then I was wondering, because you have the perceived social cohesion, but that's measured at an individual level from all your respondents. So that's nice. You could include it in your analysis as an individual factor. But could it have been interesting to also use it to also aggregate it at a neighborhood level, and that you use it both as an individual and a neighborhood level component?
Yeah, that could be my lab partner used it and aggregated it as well with diabetes. That could be a discussion later on too. That could be a possibility. Our interest, especially with these two papers, was the individual perception, especially as that we were using individual outcomes like CVD, as well as BMI. So we used individual weights as well. So that was one of our motivations for using the individual scale instead of aggregation.
Yeah.
But I can understand with your study, you don't have the individual data that, like you mentioned.
No, but you could have aggregated at the neighborhood level and then combine them, actually see whether the neighborhood level could have influenced the individual level.
Yeah.
Yes, that some kind of intra-cluster correlation, something like that.
Yeah.
That may be a next step. That would be interesting. Do I have time for another question? No. Yeah.
Sorry. The opposition will be continued by Professor van Lente, Professor of Social Epidemiology at Erasmus Medical Center in Rotterdam, and he's present online.
Dear Pro-Rector, thank you very much for the opportunity to be here online today. And well, let me start with a confession. That I hadn't been able to come all the way to Maastricht feels a bit bad, to be honest, if I now realize that you came all the way from the US. So that is a bit of a difference, but unfortunately I wasn't able, but my apologies for being online today. I did read your thesis with lots of interest. I think you had several number of excellent studies, and you published them quite a few already in a good journal. So my congratulations to you and also to your team of supervisors. Interesting, but of course also a thesis with lots of questions. So I'm also for that reason happy to join here. And the first question that I would actually like to address to you relates to one of your propositions, and actually proposition number 2. And could I kindly ask one of your parents to read proposition number 2?
Individuals are often unfairly blamed for unhealthy behavior, while upstream environmental factors that contribute to their lifestyle are overlooked.
Thank you. In essence, this, of course, is a proposition that I fully support. But then while reading through your thesis, I read chapter 7. And the conclusion of chapter 7 is actually, this study shows that harmful lifestyle factors mediate a large proportion of the association between a low socioeconomic position and cardiovascular diseases. And then I wonder, aren't you unfairly blaming individuals? Is it not exactly what in proposition 2 is what you would want to avoid? Can you comment on that?
Highly esteemed opponent, thank you for your question and comments. Within the measures that we used in terms of social cohesion, walkability, and the food environment, that's the extent of how we measure the environment. So there are additionally other factors that can consider, as well as other mediators for future work. That there was still 23% that was not explained by those factors or those environmental factors as well. And given the findings, we found 12% mediation directly from the environmental variables, 3 in the sequential pathway with lifestyle factors as well, so 15% total. So on a population level, that's still a considerable amount in terms of the effect. And
yeah, but it's also considerably lower, of course, than the lifestyle factors that you measured. So you already mentioned, and I tend to agree with you on that. Are there other factors that you actually missed leading to this conclusion?
Other factors that were measured.
Upstream environmental characteristics, for example?
Yeah, like pollution it could be is a possible other factor as well. There's in terms of unmeasured confounding, yeah, like the drivability too has been studied of late as well. So how that can be a deterrent in the neighborhood. Also
I
our
tend to think about neighborhood characteristics in that sense. Could there be other upstream factors that probably are relevant here?
Yeah, our study was also limited to the neighborhood environment and their individual addresses, and there's still other considerations like the social and work environments. So outside where our participants may have engaged and may have consumed healthier or unhealthier foods, as well as the work environment and school settings too outside their neighborhood.
Yeah, and the housing conditions, for example. I agree with that. So these are very important factors. The fact that you only find 12% resonates, of course, also the other chapters. And you mentioned already also in your presentation at the start that one of the reasons why you only find this 12% is because, for example, the food environment is not related to the outcomes. Do you have an explanation for that?
Yeah, diet, it's quite complicated in terms of our measure. Unlike the walkability and the perceived cohesion measure, the food environment is fairly unidimensional. So we're the FEHI, so the scale goes from a +5, healthy, the healthier it is, and -5, unhealthy. So it's just a single rating of the healthiness of the environment as opposed to other influences like cost or within store variation. So they might purchase a healthy item in a healthy store. And there's also, as you mentioned earlier, potential environments, the marketing environment as well. A lot of low socioeconomic neighborhoods, especially in places such as the US, have more marketing towards unhealthier products in addition to smoking and alcohol as well.
Mm-hmm. Yeah. Well, we actually tend to think that the Netherlands is also not a very good case for a healthy food environment. But one of the issues here probably, and I don't know how often you had the time in the past years to go through the city of Maastricht and to look at the food environment, but exactly the same counts for the US, is that it changed over time substantially. Yeah? So in the Netherlands, for example, we estimate that in the past decade, approximately 50% more fast food outlets were implemented. And to be honest, I can hardly believe that the food environment is not important for our population health. But it raises the question, of course, also that if we measure the food environment at one moment in time, that the variation is very little, simply because it is so bad that everybody is exposed to a very bad food environment. And as a consequence, we don't see any effect, differences between people in terms of cardiovascular diseases. Do you agree with that?
Yeah, certainly, especially with we individualized each participant address, so the approximate 1,000 meter buffer, and to an extent with the sensitivity analysis, we used 1,500 meters. But similarly, the school environment, the work environment, those are other exposures. So potentially in the future, for future research, asking participants their actual activity zones where they frequent the most, and maybe gathering those levels there as well. But from a policy level too, you're expecting your residents, your patients to eat healthier, and what we have to show the most conclusive evidence we have with the food environment is that it's neutral, so it's not healthy. And so you're expecting your residents, your patients to eat healthier, but it's still slightly negative. So that says something to everywhere.
Yeah, but we actually study this in an environment that over time becomes unhealthier and unhealthier. So if the next time you would conduct a study again on the food environment and cardiovascular diseases, would you do it differently, or do you think, well, I would still take the same approach?
Yes. So Yeah, one of the limitations of how we studied the food environment, especially in the second chapter, we measured the food environment, like you said, at one point in time. So follow-up studies, as well as gathering participant diet. And I'm not sure how the design would be, but factoring cost. So how expensive of an item is at a certain type of food retailer compared to a different one, because that cost plays an important factor, especially with participants who are low socioeconomic status. So that I would factor that in, and especially we did one measure of food frequency. So with the Maastricht study, actually, we have phase 2 data being collected at this moment. So that will give us an opportunity in the future to see if there's changes or if there's more statistical significance with the future project there.
All right. Thank you very much.
Thank you, Professor van Lente. And the opposition will be continued by Dr. Den Braver, Assistant Professor at the Amsterdam Public Health Research Institute of Amsterdam University Medical Center.
Thank you. Dear candidate, congratulations on reaching this milestone for you and for your supervisors and for your loved ones. It's very nice to be here, especially reflecting back on the past years where you were doing your PhD and we would meet each other annually in the ISPEMPA conferences. It was always nice to have a familiar and friendly face and have good intellectual discussions with. So I'm very glad that I get another opportunity to have a discussion with you today. So without further ado, amazing work, and I think neighborhood environments, socioeconomic position, lifestyle and health are all very relevant, and it's very comprehensive that you looked at all 4 of these factors in your thesis. I do feel a little bit some inconsistencies throughout the thesis, whereas in the title you indicate impact of neighborhood environments on socioeconomic health and cardiovascular disease, whereas in the framework that you present in the introduction on page 12, you frame the pathway between socioeconomic position and cardiovascular disease, where neighborhood environment is more of a mediator than anything else. So my first question would be, what is socioeconomic position in your view in the cluster of these factors?
Esteemed opponent, thank you for your comments and your question. So a little bit more specifically, so in my view of the whole, in terms of the environment or just CBD or all
I think mostly in this pathway. So you present it in figure 1 as kind of the root, and whereas in the title you present the impact of neighborhood environments more as the root. And then, like, where does socioeconomic position, is it, in your eyes, the determinant, a mediator, effect modifier, confounder? How do you view this?
Yeah, it's viewed as a exposure, and then the environment as either facilitating a positive lifestyle or making it more difficult for the participant or the population at hand as well on the pathway to health behaviors as well as CBD. So the environment itself can magnify that disparity. So we all know that low socioeconomic status, there's difficulty with health literacy and health access and advocating for oneself, and but the environment itself, as a mediator for low socioeconomic position, as it can magnify those disadvantages that those individuals face.
If I hear magnify, I think of effect modification more than mediation.
That too, but a little bit of everything.
It can be a little bit of everything,
yeah,
okay.
Yeah.
I think I can agree to that.
Yeah.
And I was wondering, like in chapter 3 on page 50, you looked into it as an effect modifier as well, and you actually find it to be an effect modifier, where you refer to supplementary table 3. I do want to ask some detailed questions. I'm sorry, I cannot help myself. So I was wondering, can you talk me through those results in supplementary table 3 and how you arrived at the conclusion that it is an effect modifier? Supplementary table 3 is on page 60.
Oh, 60, okay.
Because I had a hard time here seeing what was a high socioeconomic group and a low socioeconomic group, and in which direction the association was going.
Yeah, with this chapter, we did not, not with walkability, unfortunately, here. So with income and housing value, it was a null finding, and then urbanicity, there was significance, but it was so it was an inconsistency there. So we did not find out with the objective walkability scale, which gave us the discordant findings that we found earlier.
So if I look at income, do I look at a high or a low income group?
So the income group, you're looking at
and I see only zeros. So well, maybe this is too detailed for now.
Yeah, this, if I recall correctly, I think it might have been the high income group.
Okay, and so you looked at both effect modification and confounding, and in most chapters you perceive socioeconomic position as a confounder. So yeah, I was just thinking whether that fits into the framework that you propose in your introduction.
Yeah, in the initial chapters we used it as a confounder, and at the end we compiled all the environmental factors together to look at the impact. So
you built on
it was a summation of the previous work.
Right, okay. So you got more wise along the way. Okay, nice. Thank you. Then I'll move back to the fun questions. No. So for the causality, I had some questions because you mentioned that it's important for policy making to have causal evidence. And then I wanted to jump to chapter 5, because there you look at cross-sectional as well as longitudinal associations. And I was wondering which one you would find more important for these causal conclusions.
In chapter 5, you mentioned?
Yeah.
Okay. And can you repeat your question? What the cause?
You have
have
the cross-sectional, and I think you base most of your conclusions on the cross-sectional outcomes, and you give a lot of explanations why you did not find anything in the longitudinal. Well, I think we all agree that for causality, longitudinal evidence would be preferable. So how would you fit this in with your theory that we need causal evidence, but you do highlight the cross-sectional results as being quite important, I would say. Why are those results so important then?
Yeah, for follow-up. So, the literature has been mostly observational, and so the outcomes were collected at one single point of time. And so, with the BMI chapter, that allows to see if it was a coincidence. So, at one point of time. So, the annual questionnaires where our participants were able to self-report weight. So we were able to see a consistency between the quartiles of cohesion. And so that adds more depth than an observational study. For that chapter specifically, eventually we would want to have more of a mediation analysis.
But you did look at longitudinal evidence in this chapter. The changes in BMI, and I think it relates to Professor Van Lente's question as well, on changes as opposed to changes, and that giving more insight into causality, and that's actually what you did here. But you also give a disclaimer that there's probably other things that would have caused the changes in BMI other than the environment, because you didn't find anything. So I was wondering, is this not the avenue to causality, to do longitudinal studies, because there's so much going on?
Yeah, in the chapter 2, we only had the one social cohesion measure, so we didn't have the follow-up as well.
Okay, yeah.
But yeah, that does lead, to in the future of more longitudinal studies.
Right.
Yeah.
Okay. Yeah. Okay. Okay. Do I have time for no? No.
No, unfortunately, time is up. The next opponent is Dr. Dukers, associate professor at the Department of Health Promotion of Maastricht University and also Public Health Service.
Thank you. Dear candidates, thank you. I read your wonderful thesis with great interest and also a lot of admiration about, not only the topic, but also the methodological rigor and really comprehensive approach that you took there. So I also want to congratulate, of course, your supervision team with its excellent work. And I want to talk a little bit more about about social cohesion and your exploration of social cohesion as a determinant of health is really important. Really makes a valuable contribution to the field of cardiovascular health and also epidemiology, but also broader public health. I have some concrete questions, but maybe first, what is, in your opinion, social cohesion? What is it?
Esteemed opponent, thank you for your question and your comments as well. Yeah, there's when I first started the literature review, there were 40 different definitions of social cohesion, so you can't. It's hard to describe it, but it's a feeling that the residents have in their neighborhood environment that they can trust each other. They feel that even though that they don't personally know everyone, that they can rely on them in distress, and they could account for each other and the behaviors that they see in each other, to hold each other accountable, and basically feel comfort and safety, and not feel stress. So, the fact that without meeting each other, that they know that they're unified, and if they were to assist someone, that would be reciprocal.
Okay.
Yeah.
Thank you. So I hear trust, reciprocity. I don't hear social interaction and participation. Do you feel that is also part of that?
Yes, certainly.
Yeah. Yes. Yeah. And then I go to your work. You use two different ways to measure cohesion. The perceived scale of social cohesion and trust, which is 5 items, and it's on an individual level asked. And then you use the GECO data of the 3 items that you explained to the first opponent, and then also explained that it was not very suitable for the Netherlands, which is attract my interest. But it's kind of a more objective scale, and I wondered, there are more scales. So, I mean, we should take this further in research and also in practice, but what should we measure? Should we discard this objective scale now? You say it's not useful and only rely on the perceived scale, but what does it measure, the perceived scale? Because it is individually. Do they relate with, does the perceived relates to the objective? Can you explore that a little bit?
Yeah, I think that they could complement each other. It's hard to gather someone's feelings from an objective scale, so that's where I see the value of the perceived scale. And then, but at the same time, when like you mentioned, it's limited to 5 questions. So a policymaker will obtain that information and say, okay, the residents perceived their neighborhood as cohesive, but what are they going to do about it? And then the objective scale, they've done some validation on particular characteristics of certain communities and neighborhoods, like those 3 aspects that we talked about. And from a top-down approach, those are some commonalities that they see, some concrete measures that they can make from a municipality and a city level that can make those changes.
And based on your measures, because we go back to your work, you have measured this with the scale, perceived scale, and you recommend in your discussion to intensify social support, social interaction, and also that, in that way that you can mobilize trust and social cohesion. But I think social interaction and social support is not what you measured. There are different scales you can use to measure that. Can you reflect on that? So why did you not use the other measures then? Because you say these are important. How can you derive that from your social support scale?
Yeah, the objective of the chapter was solely measuring the cohesiveness, but probably in the future, this, as you mentioned, that social support would be, as they're interrelated to an extent as well. And if policymakers can use that for a more detailed approach on specifically what aspects of the neighborhood that the participants find conducive to being cohesive, and what avenue, and that could be the sport aspect.
Thank you. Yeah. I'm looking to the prorector.
Very short question. 2 minutes.
Do you think that it's feasible to change and intensify social cohesion in a neighborhood when you are a clinician, a physician, or a public health professional? Are you confident that it's possible that also healthcare providers can do that, and politicians?
Yeah, healthcare providers see patients individually, so we're able to listen to them directly, and like what I mentioned about planning, the more listening sessions, the more you could actually hear the particulars of what the residents in the neighborhood need and desire and appreciate.
So is your answer then
you could
yes?
share that.
Or
yes.
no?
Yes.
Yes.
You could share that with the policymakers for future work. And
thanks.
Yeah.
Yeah, very important. Thanks.
Thank you, Dr. Dukers. We now come to the last opponents, Professor De Rijk, Professor of Work and Health at the Department of Social Medicine at Maastricht University.
Thank you. Dear candidates, my congratulations with your thesis to you, to your supervisors, and also to your family. When preparing, I realized that we have been workplace neighbors for the few times that you were visiting Maastricht, because my room was next to your room. And I must also say that I have a lot of appreciation of you doing this while living most of the time in another country and working full-time, I believe as a physiotherapist, if I'm right, and then publishing 5 out of 6 papers before the defense. So I have a large admiration, but I still have some questions I would like to discuss with you. And I would like to continue with the social cohesion. It's intriguing us, I think. And I was particularly intrigued by the marvelous figure on page 71. It shows Maastricht. You also have shown it in your presentation. And then we can see that the green parts are really the prosperous neighborhoods, and they have a high social cohesion. So I started to think further, and I started to look also at your items, and I thought, to what extent are your measures for social cohesion measures for how homogeneous the neighborhood is, because they contain items like sharing the same values or having a low diversity by life stage? So can you answer this? And then I have my next question.
If I understand your question correctly, why those areas in particular on the map might have those findings?
Yeah, and is it that your social cohesion is very much indicating that there is there people live in a kind of bubbles of people who are alike, rather than that they are supporting each other, but they are alike.
Okay. Highly esteemed opponent, I thank you for your questions and comments. If you look at the map, you'll see the higher cohesive communities, like you mentioned, are in the periphery. And recalling the objective measure, the low turnover, so residents grow up and live in the same neighborhood together, and they're more familiar with each other. So they have time to grow and develop that close bond. And then I think that's one of the major factors that leads to that. Mm-hmm. They see each other more frequently and such.
Mm-hmm. Because I was also wondering whether, we tend to look always at the lower social status groups, at the lower cohesion groups, because there the problems have to be solved. But maybe your findings can be better explained by looking at the homogeneous neighborhoods where people live who had the opportunity to choose where they could live because they have the budget for choosing the place to live. So I was thinking, can your findings also be explained by sharing the same norms regarding what do you have to eat, how do you, what kind of private time, physical activities do you do? So these are is this lifestyle behavior? Is this something represented by caused by having the same values?
Yeah, that could be the possibility as well. There's, I don't know how to see if I could pronounce this correctly. Friesland. Friesland. So there's the Friesland.
The Friesland example. Yeah.
The Friesland paradox. So the residents in that part of the country are relatively lower income than the rest of the country, and they're one of the most cohesive and happiest groups of people, as we saw from a report. Similarly, they see each other more often. They're a closer knit community, and the behaviors are normalized, and so they're able to.
And they share norms about that. Yeah. I have another question, and that is, you live in the United States, and this thesis was done in Europe. When I was looking at the cover, I was thinking this is showing also an average square in a European city. To what extent is your research, and we also know that there is a lot of research from the United States or from North America, you refer to that as well, all the studies. To what extent can we regard your thesis as the or a European addition to a research on neighborhood environments in relation to lifestyle, socioeconomic health disparities and CVD?
Yeah, cohesiveness is definitely universal across different countries and continents. Similarly, as we had a discussion that what makes a community cohesive can differ, and that's the policy component right there. That's the listening to the residents. What particular aspects of your neighborhood and society, what do the residents desire and can feel that way, and that differs across different countries, possibly different cities too within the Netherlands as well. Even the walkability scale, that was derived from a national survey, and that's how that was validated. But you could see that the findings were the opposite. So, but yes, cohesion is definitely important for As we discussed, normalization, information exchange, but different ways.
Mm-hmm. And to what extent is the Maastricht area representative for Europe, do you think?
Ooh, that's difficult to say. The Maastricht study, the sample is fairly homogeneous as well, Dutch-speaking. So there's not too many immigrants included in the study as well, so that makes it a little bit hard to generalize. But yeah, possibly through the Netherlands, more studies need to do that type of research on different demographics, and even countries that are developing as well, where there's less research on that, so further studies.
So you rather regard your study as a next step in the total amount of studies on these topics, and not particularly representing. Well, we tend sometimes to say that we are the most European city in the Netherlands, but not really representing Europe, because there are also specific characteristics of our city that are different in other European cities.
Yeah, the concept is applicable. Possibly worldwide. The particular aspects of how that can occur can change. Yeah.
Okay, thank you.
Thank you, Dr. de Rijk. Jeffrey Chan, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room. Jeffrey Chan, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Bosma is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite you, Supervisor, to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? Doctoral candidate, Dr. Chan, you have to say.
Yes, I promise.
Okay, thank you. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Jeffrey Alexander Chan, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Congratulations. Close enough. Good. Okay, you can keep it. Dear Jeffrey, dear Dr. Chan, congratulations with your title of doctor. Annemarie and I hope that you are as proud or even more proud than we are. Our journey started in May 2020. At least I looked in my email folder. I saw the first one, May 2020. When you emailed the research school, Capri, for a possible position as an external PhD student. With your interest in health inequalities, you were quickly sent to me. And equally quickly, Annemarie was also on board, given that we were about to use the data from the Maastricht study, and also given that we needed expertise, input on the behavioral mediators and outcomes. In the 4 to 5 years with us, you were able to find some really unexpected findings. Firstly, walkability, including the amount of green in the neighborhood, you found not consistently related to how much people engaged in physical activity. And secondly, an unhealthy food environment you found not related to the quality of the diets that people ate. Instead, you found an unusual suspect, I call it, in the neighborhood, more important, which was the absence of social cohesion. That neighborhood characteristic was related to all unhealthy behaviors, and because low social cohesion was also more common in low socioeconomic positions, it also explained part of why people with a low income or a low education have much higher risk of cardiovascular disease in our region. The individual behaviors, to the extent that they are not rooted in measured environments, appeared most important though. As in each good research, new questions pop up. It's always the case. I keep wondering which other environmental, but perhaps also non-environmental factors contribute more, and how to improve social cohesion. And some of the questions were actually about this issue. And the king in the Netherlands recently said that Dutch society is falling apart. People do not meet each other anymore. And what to do about it? Thank you, Dr. Chan. It's an important issue. Thank you, Dr. Chan, for the robust and striking findings and the food for thought that they gave and keep giving us. We made a nice trip these past 4 to 5 years. Maybe it's good to illustrate the trip with some highlights. Highlight one was you was always very pragmatic. No mountain was too high. You just did it all. We helped you at the start with the commands needed for SPSS. And later, Rachel helped you working in the CBS environment, and Jeroen helped you regularly with the advanced methods. And you quickly picked up on the epidemiological essentials and the coding and also foremost knew to quickly apply these. Sorry, I must say, sorry if I kept bothering you too much about how to analyze, present, and interpret interactions. So we still have to learn. Highlight two was your ease in maneuvering at conferences and courses. With your driven but still calm personality, you have quickly connected to the right people in the research field. It is an asset that you actually seem to enjoy presenting your work to an audience and simultaneously seek to extend your network. As a young researcher, very important. And you did that successfully from the start. Highlight 3 were our 3 weekly meetings. These took place at 7 or 8 a.m. in the morning, your time in the US. And in the past, even at 5 a.m. In the past year, sorry, at 5 a.m. We have long thought this was really early for you. And only later we came to know that you at that time already were out of bed for 3 hours or so, in which you not only worked in the project, but also already did your daily running. So I sometimes imagine things. I know there are no beaches in Sacramento where you live, but somehow I keep imagining you running along the beach under the palm trees. But that's probably not the case, but I don't know. Most important though, Annemarie and I have always have deep respect for your waking time. And after our meeting at 9 a.m., your time, you met and helped your patients even. Highlight 4 is you living in California. It's one of my favorite holiday destinations. A man needs to dream. One dream that I have is to move to Monterey or Carmel at some point. And I always like to chat with you about things to see in California or elsewhere. I know you go with your family to Flagstaff each year, I think, and that's another favorite holiday destination of mine, along the Route 66. At some point, we might have almost met in Flagstaff at the same time, and I'm not sure. We should have met, actually. And working and living there, unfortunately, is not so much of a highlight for you anymore. And we hope you, or better still, the US, will quickly find a way out. Highlight 5 was you visiting the Netherlands and Maastricht several times. It was fun cycling together on the green carpet, the Groene Loper, when I showed you around a bit. And because you wanted to see actual environments with your own eyes, instead of only the numerical ratings of these neighborhoods in your data set, I even sent you on your own into one of the neighborhoods that has a less good reputation in Maastricht. And the anthropologist in you concluded that compared to some places in the USA, a less good reputation is relative. It's a comparative evaluation. The real highlight, though, during these visits was that you ate andijvie-stampot in our home. And you still got to tell me whether you really enjoyed it. So there are probably many more highlights to tell. I cannot remember that you or we as supervisors ever got stuck. You did it in 4 or 5 years, next to your normal job in the Veterans Hospital. It just went smooth. I do not know a better English word. It was always pleasant working with you and continuously seeing progress. That's really very good. I once said to you that communicating with you was calming to me. And that is true. I'm not necessarily keen on many meetings. But with you, I always thought, oh, it's with Jeffrey. It gives a calming benefit. There's a calming benefit to me. So I will miss that somehow. One never knows what is on the road ahead for you. Annemarie and I hope that our roads ahead will at some point cross again, and hopefully quickly somehow. And at least let us meet in Flagstaff in better times, when we both are there. So, Jeffrey, Dr. Chan, also on behalf of Annemarie, congratulations with this achievement. And I also like to involve your wife, Alyssa, and wider family in these congratulations. And Annemarie and I wish you much success and also joy. I always add that next to success, also joy. I wish you much success and joy in your further career. Congratulations.
Yeah, dear Dr. Chan, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. It's a special day for you, the finish of your PhD trajectory, and I hope you look back with satisfaction on this day and you enjoyed the whole ceremony at this university. I'd also like to congratulate your family, all the way from the United States. Very happy you could be here to support him. I'd like to congratulate the supervisor, Professor Bosma and Dr. Koster. I'd like to thank the members of the degree committee for the time they have invested in this ceremony, especially thanks to our guests from outside Maastricht University, Professor van Lente and Dr. Den Braver. Thank you for your contribution. It's very much appreciated by Maastricht University. Yeah, and with this, we come to an end of this academic ceremony, and I close the session.
Please all rise. May I invite Commissioner supervisors, please.